Welcome everyone, my dear champions, to discussion of the most important questions that appeared in the September 2025 exam. And this exam was a well-balanced exam, okay, with many of the repeated questions and many of the common topics as well. Okay, maybe some topics have a little bit of a confusion, or some questions have a little bit of confusion, but mostly it was a really good balanced exam. Let's have a look here. It's a 70-year-old with vault prolapse, known case of uncontrolled diabetes and asthma. She had previous 3 cesarean section and open cholecystectomy, laparotomy for ruptured appendix and peritonitis. She tried physiotherapy, but no effect. Cannot tolerate pessary, so sexually active. What would you choose for her? Can I choose a colpocesis for this patient? Patient have a multiple problems, including previous history of abdominal surgery. This is actually the main indication to go for the sacrospinous fixation. Yes, and the Irish guideline, this is, yes, a state on the following that we strongly recommend that women should be informed that functional and anatomical outcome are similar between the sacrospinous fixation, okay, or the abdominal sacrocolpopexy. And we recommend the vaginal paced native tissue repair, okay, may be more appropriate in women with comorbidity such as obesity or pelvic radiotherapy or previous pelvic surgery, and this is based on a best practice. Yes, well done. So next question is about patient with constipation, lower back pain, manually support required during defecation. And there is bulge in the posterior vaginal wall. What is the possible cause of this? What do you think, my friends? Fistula, fascia, or problem in which there is a problem, right? In which structure? In the fascia or in the muscle? Hmm? What do you think? Usually, the prolapse happen as a result of weak muscle, right? Correct? Okay, so which muscle is involved in the posterior wall prolapse? This is the levator ani, right? Yes, it's the levator ani. So, a gravel 3, previous ectopic right side treated with methotrexate, left salpingectomy. Now, 2 by 2 cm ectopic on the right side. The ECG is 1500, stable and no pain. What is the best choice? What do you think? What should I do if the patient have previous right side ectopic and treated with methotrexate, and the ectopic now on the same right side? Shall I go for a surgery or again treat by a surgery? What do you think? She had already left the salpingectomy. So now, if there is a left salpingectomy, Shall I go for another surgery or just to choose the methotrexate?
MMC, methotrexate, because size of ectopic is less than 35.
Yes, if it's still, yes, exactly. Look, my dear, if the medical management is still an option, you go for the medical management, no problem of that, right? So the patient, you will avoid another surgery, right? But if he give you features of ectopic, that is not actually a candidate for the medical management. In this case, there will be a surgical. And if it's a surgical, what you will do? Another salpingectomy or salpingostomy and preserve the tube.
Salpingostomy and preserve the tube.
Yes, yes. Okay? Yes, of course. So this is now, for now, as still fulfill the medical management criteria, you go for the methotrexate. But if there is in the scenario like pain detected or fetal cardiac activity detected, what you will do in this case, you will go to the option A. Okay? So this will be according to the cardiac activity and the features. If it is still features for medical management, go for the medical management, okay? So the best initial choices to discuss with the care team will be methotrexate as first line option with serial beta ECG monitoring like day 4, day 7, and then weekly until undetectable. If imaging confirm tubal ectopic and no rupture risk, okay? But if the patient strongly desire tube preservation and the imaging support the feasibility, then consider the laparoscopy to do a salpingostomy as a secondary option. Okay, but if the tubal preservation is not feasible, okay, then in this case, salpingectomy will be the definitive management. Okay, and afterwards, the only option for her to go for trying for pregnancy will be, of course, the IVF. Okay, so here is the pathway for the management, diagnosis, and management of tubal ectopic pregnancy. Okay. Here is my friend, likely options and general consideration. Okay, and this will be useful for you to revise. Now, paraurethral gland, swelling, pain, and no obstruction of urination. What is the diagnosis? Yes, it's a skinny gland. Yes, exactly. Well done. Okay. A young girl that diagnosed with AML plan to undergo cancer, okay, at 14 years of age. She had menarche and now 16 years with cancer ovary, referred to fertility clinic. What would be the treatment? Yes, of course, this will be before the treatment. Okay, if I have a younger age, she did not start puberty yet. What is her option? Younger age, but still not start puberty. Like, for example, 11 years old or something and not started puberty yet. In this case, I will think of the ovarian tissue preservation. But if she already had the puberty, then I will go for the cryopreservation, right? And this will be cryopreservation before the chemo, right? Before treatment. Yes, well done. Well done, my friend. This is, yes, this is comes from a TUG article, okay, that fertility on ice and overview fertility preservation for children and adolescents with cancer. Best treatment for cancer cervix, stage 2B, nulliparous, and we want to preserve her fertility. What do you think, my friends? In 2B, can I still preserve the fertility for this patient, yes or no? So what could I advise in this case? Chemo, radiotherapy? Radical trachelectomy? Okay. Look, my dear, Dr. Firdaus, my dear, for this cancer of the cervix, you will have, right, the fertility sparing option in the form of conization, if it's a very early stage, like 1A, okay, this is conization can be enough. Or if it is 1A2, for example, I can think of trachelectomy.
تعالي شيلي بيبي.
Please. Thank you. My God. Guys, could you please check your mics?
Is this remove this one?
Okay. Thank you. So, my friends, for the cervical cancer, right, for the treatment, for the fertility sparing option, it's very important that you remember, right, that for a patient who comes to you at very early stage, right, like 1A1, you can go by just a conization. But if it is 1A2, right, 1A2, my dear friends, I can think of the trachelectomy as a fertility sparing option, right? And in the 1A2, could you please remind me of this staging? I'll tell you, my friends. In 1A2, there is stromal invasion more than 3, right? And like 4 millimeter and up to 5 millimeter in depth. In 1B of the cervical cancer, the invasive carcinoma was measured the deepest invasion more than 5 millimeters. And this is, okay, lesion in this time, I will check for the greatest dimension. So in 1B1, I will check here. I found that the greatest dimension is 2 cm, not millimeter, cm or less. Okay, so imagine on the cervix, you have a lesion 2 cm in this part, 2 cm, like this. It's like a coin size, right? In 1B1, I can offer trachelectomy, yes or no? What do you think? In a 1B1, trachelectomy is an option, right? So up to a lesion of 2 cm in size, I can offer trachelectomy, right? And this will be, of course, radical trachelectomy, right? Yes. How about 1B2? From 1B2, my dear friends, the size of the lesion is more than 2 cm and up to 4 cm. So imagine that you have a lesion on that organ up to 4 cm, maybe larger than this, right? In the greatest dimension, like this, right? So imagine this size. Can I perform just a radical trachelectomy and preserve fertility in this patient? How about the cancer spread? How about the risk of recurrence? In the 1B2, officially, okay, the end stage to offer trachelectomy is 1B1. In 1B2, some centers, in selected cases, they can consider 1B2, but after counseling with the woman about the risk of recurrence, but it's not the classic recommendation of the guideline. So here is a very important, as we say, a landmark in the management of cervical cancer. From 1B3, 1B3 is finished. There is no option of the fertility sparing. Actually, this option is now from 1B2. We could say that no, it's not an option. 1B3 definitely is not an option. What's so special about 1B2? 1B2 special that from here, I would say that surgery or radiotherapy both are options, right, for the patient. Surgery can have its success rate, but will have higher mortality and higher side effect. And in the same time, primary radiotherapy can work. So from 1B2, it's to be or not to be radio or surgery. From 1B3, actually 1B3, we can, yes, perform a surgery, but the complication and the mortality from the surgery is higher than combination of chemoradiotherapy. So from 1B3, actually, start use of what? Of the CCRT. Okay, so it's like a song. Please remember it, okay? From 1B3, start use of CCRT, combined or concurrent chemoradiotherapy. Now we'll come to stage 2. Stage 2, that definitely not a surgical, and definitely, okay, not a fertility sparing stage. We'll speak about stage 2. In stage 2, you find that carcinoma invade beyond the uterus, but has not extended to the lower third. So it's in the upper 2/3. In 2B, this is our stage in the case. In 2B, the carcinoma with parametrial involvement, but not up to the pelvic wall. Can I preserve the fertility in this stage by any means? What do you think? In 2B, no, there is no way that I can preserve the fertility in this case. So what is the official treatment? What is the standard treatment of 2B of cancer cervix? Standard treatment is chemoradiotherapy starting from 1B3. So 2B is for chemo and radiotherapy. You get the point, guys? So it doesn't mean that if the patient wants to preserve fertility, that I have to fulfill her wishes, right? Unfortunately, I wish I could help, but unfortunately, this is not an option in her 2B. So what could be an option? You know what? If there is an option of cryopreservation, okay? Cryopreservation. And then she can have a surrogate, okay? This can be an option. Otherwise, no, okay? So what is the treatment, my dear friends? Best treatment for cancer cervix stage 2B is chemoradiotherapy. Okay, that will be a chemoradiotherapy. Remember, from 1B3 comes the rule of the CCRT, combined or concurrent chemoradiotherapy. Okay. So I wish that there is, okay, a good option for this lady, apart from this option, but what to do? Okay. Have a look in the exam very carefully to the stage or the description. Okay. Staging of cancer cervix is very important, especially when it comes to the fertility sparing options. You have to know which stage and are eligible for the sparing option and for staging and corresponding treatment as well. This is criteria for fertility preservation and for the cervical cancer. Okay, histological type, it is squamous cell carcinoma, adenocarcinoma, or adenosquamous. Tumor size, lesion is 2 cm or less, no deep stromal invasion, no evidence of lymph node involvement, no distant metastatic disease. Okay? But in cancer treated with radiation therapy, especially in young patients, ovarian transposition could be proposed to limit the effect of radiation on ovarian reserve by removing the ovary from the radiation field. So this is, as I told you, if this is an option, I would go for this option. Okay? A young patient that is presented to the A&E after 18 hours of abdominopelvic pain, ultrasound shows 7 cm tube ovarian mass. Best management. What do you think? For a tube ovarian abscess, what would you suggest as the first line? Look, my friends, we don't do interventions, okay, unless we have no response of the antibiotic in case of the tube ovarian abscess, okay? After 24 hours, we think about the interventions, right? That's the action, okay? This question had two possibilities. I'm really not sure if this was the correct, question or not, but this is 18 hours of abdominal pelvic pain. If it is pain only, right, and there is a tube ovarian mass, right, this could be a mass or it could be an abscess, right? So I needed more details, right, about the pain or about if it is tube ovarian abscess or just a mass, right? If from the scenario I'm thinking that this is a tube ovarian abscess, I will go to the antibiotic and IV fluids, right? If it is from the scenario that it's acute pain due to, for example, torsion or due to ovarian accident, I will go for the laparoscopy. Correct? So this will depend on what? What do you think, my friend? This will depend on the presentation, the complete presentation in the exam. Right? So the guys, if you have attended the previous exam, the September exam, okay, you can please send me if you have further detail about it. If there was further detail regarding what was the features of the mass. Is it only pain or it is associated with fever, for example, or signs of sepsis? Okay. So far, my friends, if you're thinking that in the exam, right, that this is an ovarian accident, go for urgent laparoscopy. If you think it's a tube ovarian abscess, go for antibiotic and IV fluids. Okay, good. Okay, friends? There is a previous recall actually regarding acute pain in young girl. If it is acute pain in young girl with adenoxial mass, think of torsion and go for laparoscopy, urgent laparoscopy, okay? If it is only pain, but if it is associated with fever or signs of sepsis, that means it's abscess, that means you go for IV. Antibiotics, yes. Here, in a patient who had what do you think in this patient, my friends? Just on day 18 of the cycle, and her cycle is regular, and she's young, abdominal pain, minimal fluid with small clear cyst in ultrasound. What do you think the finding is? Corpus luteum cyst? Yes, of course. Okay. Yes, that's true. Okay. Patient had ERBC 6 hours ago. Now her IMU 2, 38-degree, febrile, otherwise stable, no pain, no hemorrhage. What would you do in the next 3 hours? What do you think, my friends? Stable, no pain, no hemorrhage. What you will do in the next 3 hours? And her IMU is 2. Are you going to deal with her as sepsis or just repeat vitals after 30 minutes with oral fluid, or initiate 6 bundle or repeat in 30 minutes and give IV fluids? Which one? Okay, very important, my friend, for this exam that you know what are the features, okay, or the management of the IMUs. What is the IMUs? It's of course for Irish, right? Modified early scoring, right? System, yes. So the principles of the documentation and the triaging of acute ill women are almost the same between the the guidelines here and there. But the thing is that in the Irish, right, there are certain recommendation on how to react based on the finding, right? And you have to know how to go through this, right? Okay, so The finding of fever 38. What is the action based on that? This is in the yellow zone, or this is in the iMuse trigger key. This is in the yellow zone, or this is in red zone, okay, or in the white zone. Look here, my friends, this is the iMuse trigger key of the RCPI, okay? So here, for the temperature, if the temperature 36 to 37.4, this is normal value. But if the temperature is high, between 37.5 up to 37.9, okay, this is yellow zone. But if the pink zone means that temperature is 35 or less, hypothermia, which is of course can happen in cases of septic shock, or fever 38 and above. So this is a pink zone, right? What you will do if you have a feature in the pink zone, according to the recommendation? Look, my dear, here, for the all iMuse triggers, okay? If 2 yellow or 1 pink, call the obstetrician to review. Repeat a full set of observations after 30 minutes. Okay? So here what I will do, according to the iMuse trigger, if I have 1 pink, which is already the temperature 38, what do you think, my friends? Now, I will repeat the vitals after 30 minutes. But the question here, shall I give oral fluid or shall I give IV fluids? Based on a temperature 38 only. What do you think? I will give oral fluids. When to give IV fluids? You will give IV fluids in case this case have suspected sepsis or she had hypotension. Clear, my friends? So why would we choose B? Because the temperature, right, is pink feature. It's 38. And if it's a pink feature, that means I would repeat the assessment in 30 minutes or after 30 minutes, right? Shall I give for the fever in a stable patient, no pain, no hemorrhage? I will give oral fluid or IV fluid. I will give oral, of course, right? I hope it's clear. This is also, again, important notes for the management of patients suspected for infection, but stable. Here, a 26-year-old with squamous cell carcinoma, stage 2B. What treatment will improve 5-year survival? Squamous cell carcinoma. In 2B. Which treatment is better for survival? What do you think? Is it the surgery, or it's the chemo, or chemoradiotherapy? Yes, of course, it's a chemoradiotherapy. So radio is for the local disease, right? Chemo for any systematic metastasis here or there, right? So you are ensure you are fighting without a destructive surgery, right? So you are fighting the cancer, right? Yes, well done. A 14-year-old raped by her friend, brought by the Sato, okay? The case with penile vaginal penetration. So, what would you do? Yes, of course, you will refer or inform the TUSLA. Yes, exactly. Okay? What is the value of hymen examination, Dr. Shakila? No, right? It's her safety. For the referral and safety, you have to know, okay, what you do with the cases of sexual assault. Okay, so the answer will be refer and inform to TUSLA, and this is Child and Family Agency, and ensure child protection or safeguarding procedure are initiated immediately. So our priority is the safety and well-being of the child, no delayed investigation for forensic evidence unless the minor or guardians request to do this. Okay? Okay, my friends? 36 weeks in pregnancy, collapsed, admitted with cough, fever, pleuritic pain. When you reach the patient as not breathing, what is the best initial action? What do you think, my friends? Initial action? Will I go for check pulse first or check compression first? Start chest compression. Which one first? Have to ensure that this patient is pulseless. Yes, correct, everyone. Yes, of course. Okay. This is my friend again. This is for the obstetric emergency training nationally, right? This is the maternal collapse, and this is their steps, okay, for the maternal collapse, okay? And they are saying that it could be subdivided into collapsed but responsive, collapsed but unresponsive, with or without a pulse, okay? So you need to know if this type of arrest is a cardiac arrest or this is a respiratory arrest, okay? here for the management of the maternal collapse. You put the patient in the left lateral position, call for help if appropriate, check maternal observation, assess fetal well-being, and call for obstetric review. If the patient is unresponsive, open airway, look for signs of life. Okay? Wedge or tell to the patient, call obstetric resuscitation team in the same time, and start on the CPR. So very important that you check for the observation and check for the pulse, right, before you are commencing, and open the airway before you are commencing the CPR. And here, right, in their presentation, in the training, as I told you, for the obstetric emergency in Ireland, if the patient is collapsed and unresponsive, this will depend on the pulse present, yes. So place in left lateral position, measure the blood pressure. No pulse, activate the emergency response team. Commence a basic life support. Start with compression, airway, and then breathing. Clear, my friends? I'm going to share this resuscitation slide with you, okay? Just please remind me on the group. If you find that I forget this, please remind me. Tell me, Dr. Rabah, please share the iMuse and share the maternal collapse, okay? Both are very important to know how to manage the emergencies, the stepwise approach, okay? Okay, Dr. Firdaus, is that clear, my dear, for you? Stepwise approach? If the pulse is thick, it's checked already, and the patient have no pulse, you start on the chest compression. Okay, good, thank you. Episiotomy infection prevention after operative vaginal delivery, what you will do to prevent the infection? After instrumental or operative vaginal delivery. Use of non-absorbable monofilament, decrease the infection, or absorbable braided suture, decrease the infection, or IV antibiotic when infection occurs, or one dose of antibiotic prevent infection, or breastfeeding increase infection risk. Yes, exactly. It's one dose of antibiotic following the operative vaginal delivery to reduce the risk of the infection. And which antibiotic we will choose? What do you think? Which one? It will be intravenous amoxicillin and clavulanic acid, or a similar broad spectrum antibiotic would be recommended following assisted vaginal birth. Okay, as this is significantly reduce superficial or deep perineal wound infection. Yes, well done. Yes, and here in the guideline is a recommendation for intravenous. Yes. A 28-year-old, 32-year male, married for 18 months, want to conceive. Wife all normal, husband have teratozospermia. What is the teratozospermia? What is the problem in it? Terato means that abnormal form are less, right? It's coming from teratogenicity. And azoospermia, this is for the numbers, right? To reduce number abnormal forms. He is a smoker and he's a truck driver. BMI 35. What is the best management? Next step. ICSI or IVF or lifestyle changes and recheck semen at 8 weeks, or lifestyle changes and the recheck semen 6 months, or giving gonadotropin. Yes, it's very important to correct the lifestyle, right? And recheck in 6 months. Yes, well done. Patient on tamoxifen, now bleeding. Transabdominal ultrasound was done and recently, and it show that thickness more than 3 millimeter. What is the best investigation? Look, my friends, for the patient, right? For the patient, okay, who had tamoxifen, right? She's using tamoxifen. The clear recommendation is to go for what? To go for the hysteroscopy and biopsy. But in this recall question, okay, your friends told us that there was no option of hysteroscopy and biopsy. So, unfortunately, right, this was my best, right, option. Let's see the recommendation here. Okay, see that we recommended that women on tamoxifen with abnormal uterine bleeding are offered diagnostic hysteroscopy with endometrial sampling as well as transvaginal ultrasound for assessment of the endometrium in these women who is not a useful tool for triage. Okay, we suggest transabdominal ultrasound should be used to complement only the transvaginal ultrasound where there is an enlarged uterus or pelvic mass. So it's not for the transabdominal, it's not to assess the endometrial thickness. We recommend that isolated dilation and curettage should not be used as first-line method for obtaining endometrial sampling in the investigation of postmenopausal bleeding. We recommend that endometrial sampling in the form of office-based biopsy is used in conjunction with the transvaginal ultrasound with or without hysteroscopy for the investigation of women with postmenopausal bleeding, but the blind endometrial sampling in isolation is not sufficient for investigation. So I couldn't choose in this case the people. People is wrong, right? As it's a blind, right? However, I couldn't find the hysteroscopy and the biopsy. So what else from the remaining option can be chosen? Yes, it's running a TVS. Yes. Okay, my friends? So again, in your exam, patient had postmenopausal bleeding. She is on tamoxifen. First recommended action is hysteroscopy plus biopsy. It's not there, so at least have a TVS, okay? And the people cannot be done alone, right? So I will here only choose the TVS because there was no option of hysteroscopy and biopsy. And she had only TAS. Yes, so this is, I told you, this can be very easy, but in the same time can be tricky. A 34-year-old with one previous miscarriage just had her second 8 weeks miscarriage, asking for cytogenetic analysis. What would you do in this case? "34 with one previous miscarriage had second 8 weeks miscarriage, asking for cytogenic analysis. Would you consider it if the age is 34? Yes or no? Or would you do it after third miscarriage only? Which one? Can I do it? The guideline says that, look, my friends, guideline says what? If the patient age, right, is less than 35 and she had 2 consecutive miscarriage, will be done cytogenics on the pregnancy tissue. But if less than 35 years with 2 consecutive miscarriage and no pregnancy tissue for the analysis, perform parental karyotypes. Okay? So I can do it for a patient who had 2 consecutive miscarriage and no living children, right? And her age is less than 35. Okay? If the pregnancy tissue is present, what would I do? If the pregnancy tissue are present, I will go for the cytogenic analysis. If not present, in this case, I can do it on the parental karyotyping. So it's according to pregnancy tissue available or not available. Okay? So if less than 35 and 2 consecutive miscarriage, perform cytogenetics on the pregnancy tissue. If the pregnancy tissue not available, then I will go for what? I will go in this case for the parental. Okay? If she just have her miscarriage and the pregnancy tissue is available, go for her consent, no problem. Right? But if he said that she comes to the clinic sometime after the second miscarriage, in this case, do it with the parental karyotype. Okay, guys? Is that clear? This short-term side effect of HRT in postmenopausal patient with vasomotor symptoms. What is the greatest risk if used for short term? Yes, this is straightforward. Of course, if it's short term, this will be thromboembolism. Yes, exactly. In a 25 weeks pregnant, she presented with PPROM and regular painful contractions, 2 cm dilated, temperature 38.5, tender abdomen, otherwise stable. Baby CTG is good, cephalic, and clear liquor. They informed the neonatologist. So what would you consider now? A very important thing to consider. Okay, so why would I do an emergency cesarean, Dr. Shakila? You know, if there is an option of antibiotic, I would go for the antibiotic, right? I would go for the antibiotic definitely, right? Okay, but if it is not there, right, what would be the most important medication to give for the baby, especially that there is regular painful contraction? Yes, it will be only the steroid option. But believe me, if this question appear in the exam, okay, I hope that there is antibiotic to be given, right? Or at least if they want to mention the steroid, okay, then in this case, I will give the steroid and the antibiotic together. This will be good. But best, right, is to give antibiotic in this case. And I'm a little surprised why antibiotic is not there. But anyway, steroid can be a good option or next option for them, right? No need to run a cesarean section in this case, guys, right? Because cesarean section in this situation will only increase risk for the mother without affecting the survival of the baby, right? Yes, she should have. If even if there is a chorioamnitis, right? Even if there is a chorioamnitis, right? Will I go for the chorioamnitis, go for cesarean section immediately? Yes, this picture is highly suggestive of clinical chorioamnitis, intraamniotic infection, right? That's because the maternal fever, uterine tenderness, and the PPROM as well, okay? So what would I do? I would give immediate, right, broad spectrum antibiotic, okay? But if the patient already start painful contraction and she would progress normally, this will be better for her, okay? Right? I will go for the antibiotic, Dr. Maha. If there is antibiotic and steroid in this case, I will go for the antibiotic. Definitely, I will go for the antibiotic. This lady, she need immediate antibiotic, IV antibiotic, right? And if you ask me which one have the priority, is it the maternal life or the fetal life, I will go for the maternal, right? So it's just that I have received a call like this, to be honest, okay? And also, to be honest, okay, if I have the ability to add option, I will add the antibiotic and choose it 100%. And again, if there is anybody have attended this exam and they know that there was an option of antibiotic, please tell me. Right? So I will write a note in your file, the file that I will hand to you, that antibiotic is required. Okay? Same question. Yes. So Dr. Firdaus, there was any other option? Was there any other option of antibiotic or something? No. So this is what we found, unfortunately. Yes. So I will only give IM steroid in this case. Thank you, Dr. Firdaus, my dear. Pregnant patient, and she's at 36 plus weeks, HIV infection with viral load less than 50. Okay? And on ART likely, good control. Right, for 3 days. Group B streptococcus is positive. what you will do? You already have two indications to start induction of labor, right? So please go for the induction immediately. Yes. Yes, of course. Primary, 33 weeks. PPROM, absent membrane. Variable decelerations. And BV, OS is 6 cm. Clear liquor. What you will do? Look, friends, can I perform a category 1 cesarean section on only variable deceleration without telling me this is with concerning characteristics, this is without a concerning characteristic, this is repetitive, this is for how long? They didn't tell me anything, right? So this could be a variable deceleration, but not repetitive, not concerning. Or it could be repetitive, concerning, and more than 30 minutes. So it's according to the type and duration of the variable deceleration. So what is needed to build a decision in this case? Need the CTG, right? Yes, continue the CTG monitoring, then decide. Correct? Yes, please continue the CTG monitoring and then decide. Post date, induction of labor. Prostein is given, ARM and syntocinon. After the synto, the CTG shows late deceleration for 20 minutes, which afterwards resolve it. What would you do now? If the CTG was very bad, show late deceleration, but it resolved it, what you will do? What do you think, guys? If the CTG show a late deceleration, and by the way, the NICE guideline is updated and they consider that the late deceleration only is pathological. But anyway, it resolved it, so we are all happy, alhamdulillah. Fetal blood sampling? No, we don't recommend fetal blood sampling. So, fetal scalp stimulation and reassess CTG. Change position and IV fluids. Category 1 or category 2. Why no screen? Look, my friends. Change position and IV fluids after resolved already, or fetal scalp stimulation and reassess CTG. Which one sounds better for you? So you all choose to have the conservative measures, right? Are we all okay? Yes. All okay, guys, with option C? Changing the position and IV fluids? That's okay. Good. Nali para. Baby is more than 95th centile. Now fully dilated. Passive stage for 1 hour. Passive second stage for 1 hour. Now start pushing. 30 minutes later, you've been called as a CTG show persistent late deceleration. Vertex at the spine, occipital posterior. So what you will do? This is high risk of failure of what? Failure of instrumental delivery in this case, right? Well done. Okay, so, but still, can I perform the instrumental delivery in theater? If the instrumental delivery high risk of failure, okay, I can see some of you choose the category 1 cesarean section. Unfortunately, no, we can't do the category 1 cesarean section in this case. Yes, it's a CTG, persistent late deceleration, right? Correct? Yeah, anyway, you will move to theater. And while moving to theater, there is no contraindication here to perform instrumental delivery. Even if high risk of failure, you can reassess the situation and consider the instrumental delivery, right? If it's all okay, you will deliver by the instrumental delivery. If it's not, you will go for the cesarean section, right? Correct? So the best option available here in between, yes, the option given is to reassess and instrumental delivery in theater. Clear, everyone? Yes, yes, it will be rotational mid-cavity forceps. Yes. A primary gravida progressed well. ARM done. After that, oxytocin is started. After 4 hours of oxytocin, bradycardia for 4 minutes and then recovered afterwards. She is now C8cm dilated. What you will do? Stop Cento. What is the most safest option? Yes, for sure, this is a stop Cento. Well done. Well done. This is the most safest option. Yes, of course. After this, you will reassess the whole situation. You can continue the CTG and watch for the progress. Yes, well done. If again bradycardia, you will take action immediately for labor. Acute prolonged bradycardia, this will be category 1 cesarean section. If not recovered or it's repeated again. So that's why stop the Cento is the feasible option in this case. Okay? Yes, well done. Incidental finding of 7 cm fibroids in 27-year-old asymptomatic. I love you too, my dear. My God. What you will do in this case, if incidental finding and asymptomatic, it's an intramural fibroid. If the intramural fibroid does not cause a great distortion of the cavity, then it's fine. Reassure. Yes, well done. Well done, my friends. A 31-year-old with irritability and mood swings before menses. What is the option? We never go retrospective, right? Okay, so shall I go for PMS diary or shall I go for a daily record of severity of problems? Look, guys, there are different questionnaires, okay, for the PMS, right? And here, there are many patient-rated questionnaires available. However, the daily records of severity of problems remain the most widely used as it's simple for patient to use, okay? This is from the guideline itself. This is a screenshot from the guideline. Okay, my friends? So it will be option, the last option, okay? You would choose the daily record of severity of symptoms. And should be, of course, in the future basis. That's mean it's prospective, not a retrospective. However, because each questionnaire has a specific name, you will need to use the same name came in the guideline. Okay? So option is 4. Answer is option 4, right? And this is again the reference of this answer, that there are many, right, patient-rated questionnaires available. The daily record of severity of problems remain the most widely used and simple for patient to use. Okay, and this is found consistently shown to provide a reliable and reproducible record of symptoms. Okay, clear everyone? So here answer is 4 in this question. This is again like helping you with the different names of the questionnaires, and remember that we will go for the DRSP. I hope it's clear. A postmenopausal patient with a small bilateral ovarian complex cyst, ascites, multilocular, with solid area and intracystic papillary projections. No other signs or symptoms. What is the diagnosis? What do you think? This will be our last question of the discussion of September 2025 exam today. And hopefully that we will be able to continue our discussion for the next week. What do you think, my friends? What is this description in a postmenopausal and small bilateral ovarian complex cyst associated with ascites and multilocular and solid area intracystic papillary? No other signs or symptoms. What's your diagnosis? Immature teratoma in this age in a postmenopausal, are you sure? Oh, mucinous cyst adenocarcinoma should be large or small, Dr. Asma? Yes. So the serous cyst adenocarcinoma, is a strong possibility actually in this question. Okay. But is it here for the description, right? The solid area and the papillary projection. This apply more for the borderline ovarian tumor, small in size, and the patient is asymptomatic, or apply for the serous cyst adenocarcinoma. The question again. Are you happy now, everyone? Yes. So this is the borderline, okay? As it's a small, complex, multilocular with solid area and the ascites. This is suggest of the borderline, as it's asymptomatic and diagnosed on incidental finding or routine examination. Okay. Okay, my friends, thank you very much, guys, for attending today.